it's wonderful having Dr. LeShervin as a colleague. And share my screen here. All right. I have another. Oh shoot, I have another screen attached. So now is that in presenter mode? Yeah, or like, can you see just the slide? Okay, great, thanks. So what I want to present is it's a mixed methods analysis of healthcare and competing needs in family life for young children of immigrant and U.S. foreign mothers. This group, I think, knows a lot of background and context. So I'm like skim through it very quickly for the two studies that I'm going to present, and then talk a little bit about a quantitative study I did focus on healthcare hardship and a qualitative study that's complementary, and then some sort of broad conclusions about both of those. So this, I'm sure, is familiar statistic to everyone here. 1 in 4 children in the United States, or actually more than that now, is a child of immigrants. And here I'm using immigrant broadly to include a variety of statuses. So everything from naturalized US citizens and legal permanent residents, refugees, asylees, and folks without documentation. So, you know, all kids' health is affected by their use of healthcare and their ability to, their family's ability to meet other needs. And early childhood in particular is a really sensitive period where that's really in need of separate research and focus. And it's a really rapid period of growth and development that lays the groundwork for lifelong health and social emotional well-being. So that's kind of the nexus of what I want to talk about here, which is that children of immigrants, we also know, have disproportionate levels of family and material hardship, whether that's food, housing, utilities, or healthcare. And that's despite the fact that there are similar levels of parental employment. And some key factors in that are length of residence in the US and also immigrant race and ethnicity. So typically higher risk for hardship for those who have been here for the least amount of time, particularly those here less than 5 years. And that's, I'm sure, familiar to you as being related in particular to SNAP and Medicaid policy that bars immigrants who are otherwise eligible if they've been here less than 5 years. And then Black or Latinx immigrants are more likely to have hardship compared to white immigrants. And that's really not something inherent, obviously, but an outgrowth of the structural racism that's really embedded in US institutions and society. Some other forces that are really important that are kind of at the intersection of healthcare, public assistance, and immigration. I'm quite sure you guys know all about public charge, but you know, it's relevant to those who are trying to adjust their status from to become an LPR here in the US, but has wider ripple effects to immigrants with many other statuses because of a lot of the fear that's related to it. It's not something that's new, and in this environment we've had of accelerating anti-immigrant sentiment, so not just related to the Trump years, but frankly also many years before that. There's been a lot of fear and confusion, and the confusion really comes in because it's this complex set of laws that not just public charge, but others as well, that limit access to care for people with varying types of immigration statuses, ages, and lengths of time in the US. Public charge in the past and currently has applied just to cash programs, so TANF and SSI, and less relevant for young kids, long-term government-funded care. And you know, there's work right now underway at the government level to codify that, because it's right now it's just like a guidebook that's being used. And then there's a bunch of rumors that have circulated for years around public charge as well, having to pay back benefits, you know, that you might be conscripted into the military if you receive any kind of help. And then the other fears that have been very real in recent years of deportation and inability to become US citizens, and sort of all of that together has this chilling effect on people's access to benefits that they may otherwise be eligible for, but they're afraid and confused by all the rules. So the research here, I'm just going to skim over this very quickly, is sort of trying to fill some gaps in the research, particularly related to healthcare utilization, related to, you know, the fact that there's a very little focus on early childhood in some of these concepts. So foregone care, which I'll talk about more in a minute, has really not been explored much in young children, and certainly not in young children of immigrants. Health cost sacrifices is something that I'll define it all in a minute, that is just like presumed in research, but not actually defined. And then there's not really a lot of work that looks at multiple material hardships at one time and how families manage those different competing needs, and especially how healthcare fits into that mix. And then really hearing directly from people about their experience of that and their experience of the chilling effect. Although the last year or so, there's been a lot more coming out. And then all of that in the context of trying to understand, you know, in this really multifaceted world we're in of interconnecting identities, we just really need to also think about the relationships between race, ethnicity, and nativity, which obviously is the focus of this group. So all the data that I'm going to present here is Children's Health Watch data. It's a research and policy network, like Dr. Sherman said. It's this is bringing 5 site data. We had a site in Baltimore for many years, and our focus broadly as a group is informing equitable policies, evidence to improve early childhood health and family well-being. So the quantitative data that I'm going to talk about comes from survey data collected pre-pandemic from caregivers who were interviewed in pediatric emergency departments and primary care clinics in 5 US cities, all kids under the age of 5, and it's cross-sectional data. And then during the pandemic in the fall and early part of 2021, I conducted semi-structured interviews with immigrant mothers who had participated in the Children's Health Watch interview in the all moms in the greater Boston area. So that's qualitative data. So the first study is really, again, focusing on this concept of healthcare hardship and maternal nativity and race ethnicity. So it's getting to terms. So foregone care, you may already know, is when people don't get care that they need, health care that they need because they couldn't afford it. And in the Children's Health Watch survey, we measure it both at the household level, so anyone except the young child, and then for the young child. So again, that's a lack of being able to afford it. And then the kind of mirror image of that is health cost sacrifices. So that's, you paid for healthcare, but now you're struggling to pay for other needs, and that the two things together really speak to sort of the budget squeeze that families experience. And my interest is in who's experiencing that, and then also child health and development and family material hardship and how those things are related to this. So healthcare hardship broadly is either one or more of these conditions. So skip there. So this again is the data set. So our survey has lots of information on child health and development, material hardships, family demographics. So we have self-identified maternal race and ethnicity. We also have maternal country of origin, and then length of residence for those who are born outside of the US, but we don't have information on immigration status. Like I don't know whether they're citizens or, you know, refugees or asylees or whatever else. The sample for this study is about 41,000. All the children in this sample are US born. I limited to birth mothers only. The kids on average were about 18 months old and moms were about 27. A little less than 22% reported healthcare hardship. Of those, the vast majority were US born, but there were about a fifth that were immigrant. And then overall, this is a sample with very high health insurance coverage for the children, so about 87%. Looking here is the distribution of the sample. So on the left is US born. More than half are Black non-Latina mothers, that's the purple. The blue is the Latina mother, so about a fifth, and then the green is the white non-Latina mother, so almost a quarter there. And then just a smaller percentage that are other or multiple races. And on the right is the immigrant, and the vast majority were Latina mothers, and about a third were Black non-Latina, and then just small proportions of white non-Latina and other mothers or multiple mothers who reported multiple races. I'm not going to go through great detail here, but here's I use logistic regression. The outcome here is healthcare hardship. I'm not presenting that, but I do also have the information by each individual hardship. And then the predictor was the mother's nativity. So US born versus immigrant, and then the US born group is the referent group. And I looked at this overall and then stratified it as well by race, ethnicity, and then also looked at an interaction term and adjusted for a variety of socioeconomic and demographic variables. So this is what I'm hoping really to talk about. So here on the far left, you're seeing the main effect for immigrant mothers. So it's like demonstrating greater odds of healthcare hardship for immigrant mothers compared to US born mothers. So here the referent is US born. And then moving to the right, the referent here is Black non-Latina mothers, and then whatever the relevant nativity is. So for US born Latina mothers compared to US born Black non-Latina mothers, there's really no significant difference between the two groups on their experience of healthcare hardship, but there was a significant difference among immigrant mothers. So immigrant Latina mothers were less likely than Black non-Latina immigrant mothers to experience healthcare hardship. Now this is looking, comparing to white non-Latina mothers. So the US born white non-Latina mothers were more likely to experience healthcare hardship than US born Black mothers. And then white immigrant mothers were much less likely than Black immigrant mothers to experience healthcare hardship. And it's a similar pattern for mothers who reported being other or another race or multiple races. So more likely to have it if they were US born and less likely to have it if they were immigrant. And then this is really this interaction term results, and really the bottom line here is that's the effect of being an immigrant is significantly different according to racial and ethnic groups. And I think what's really the most important part here, anyway, from my perspective, is that in particular the effect of being an immigrant is more pronounced for Black and Latina immigrant mothers, but not significantly different from each other. And then this is the other part of the study, was looking at how healthcare hardship relates to child and family health. And basically the summary is that unsurprisingly, I think importantly, healthcare hardship was associated with greater odds of fair or poor child health, greater odds of developmental delays, household and child food insecurity, energy insecurity, and housing instability. And I'll just quickly define those. So food insecurity, I think probably people know, is inadequate access to enough healthy food. Energy insecurity relates to utilities, so inability to afford enough utilities. So in cold places, heating, and hot places, cooling. And also housing instability. It's a measure we use in Children's Health Watch. It looks at any one or more of homelessness during the child's lifetime, being behind on rent, or having made multiple moves in the last year. So I think what I really take away from this is that it's really important to dig deeper, that the nuances in the different experiences are really obscured if you only look at nativity or you only look at race ethnicity by itself. And that it's interesting to me that among the US born mothers, the white and other multiple racist mothers are actually more likely to report healthcare hardship than Black, non-Latina, US born mothers. And on one level, that's really encouraging for Black and Latina mothers, given, lots of evidence that we have of access to care for women of color and a long history of racial bias in US healthcare. And this is not data that I'm showing here, but it's something I've started to dig into more, that the variation in health insurance rates may really be partially explaining that difference and the immigrant one, in that the Black US born moms have high rates of public insurance. The white and other multiple racist moms have more private insurance, and then they get to like the cost associated with care. And then on the other side, among our immigrant mothers, they're much less likely to be insured. And then obviously there are, implications of people not getting the healthcare that they need for future cost to society and for themselves financially, and they're, suffering truthfully. So we can come back to some more of that, but I want to also present some sort of complementary results from the qualitative study. It's a quote from the study, Who Takes Care of the Mom, the daily experiences of immigrant mothers navigating healthcare and family life. So the key questions here that I was trying to answer were really, how do immigrant mothers of young children navigate everyday needs, including healthcare within the context of the family budget, and what are their perceptions of their young children's health and their own sense of safety and comfort in accessing healthcare and other supports for their children in the current political and social environment. So eligibility for this were, again, birth mothers born outside of the US, previous participation in the Children's Health Watch study. So they all had participated sometime between 2018 and early part of 2020. I sent them opt-out flyers and then called them and invited them to participate, and they provided verbal informed consent. On the recruitment side, there was a fair bit of difficulty recruiting Latina mothers at first. Once I reached saturation with mothers from other backgrounds, I really tried hard to spend my time recruiting Latina mothers because I knew that there might be a really specific experience there. In the end, conducted 30 semi-structured interviews with a guide that was really informed by emerging findings from the healthcare hardship study that I just presented, as well as another one that I conducted. And found that the mothers were very diverse in their immigration status, their length of residence, their country of origin. So some of that is here. More than half were moms from the Caribbean, including the West Indies. About a fifth were from West and Southern Africa, and then almost a third were from Mexico, Central and South America. They had really varied immigration statuses as well. Almost 3/4 had some kind of legal status in the US. About half were naturalized US citizens. Thinking back to the public charge, I think that's relevant to think about for that. So I did these interviews in English and in Spanish, and the sort of core topics I was focused on were, again, meeting family needs, the healthcare experience, and then the current climate. I did want to point out the demographic questions. I asked them about their country of birth and their self-identified race, ethnicity, and that I would be really interested at the end to hear from other people about that, because talking to people about like how they saw themselves, the categories we use in the US were just like utterly irrelevant to them. So I didn't actually put any of that in here, but that was something I'd love to hear from others about. So then analysis wise, did inductive and deductive analytic strategies with thematic content analysis, and reviewed and discussed the transcripts looking for general themes, using tenets of grounded theory, and used an analytic synthesis template for emergent themes and the framework informed constructs. Ultimately came to 5 themes, which I'll walk through. The first is economic strain is persistent. So this really was something that I heard over and over and over again. This is an ongoing way of life. For some, it was really since they arrived in the US, because they had maybe more privileged backgrounds in the countries of origin. But for others, it was a lifelong experience. And the moms were really, really clear with me that this was not new to the COVID pandemic, although COVID had certainly exacerbated it. And they talked a lot about the constant mental calculations of every expense and every need, and talked a lot about sort of the mental weight of that. And then, when something unexpected happens, how that sort of could, blow out their plans and also their stress levels. So this quote is from a Nigerian mother who couldn't afford to fill her heating oil tank, so she used space heaters, and then got a $2,000 heating bill. And she said, they send me, when I open it on my email, I feel stressed, like I just freak out. I don't even know how to deal with that. I'd like to pay it all, but I really can't afford it right now. So just like even seeing the email is super stressful. And then we talked, obviously the focus was on healthcare. So the second theme was children's healthcare is prioritized. And really that healthcare was it's like its own budget to balance. So it was like, healthcare was a need within the broader family budget, but then within healthcare, it was this own balancing act. And they really prioritized based on perceived risk. So children and elders, if they were in the household, were number one. And moms were often sandwiched between two generations, and mothers, regardless of who else was in the household, was always last. But moms were really, really dedicated, and they were willing to anger their employers, lose income, incur medical and credit card debt if their child needed healthcare. And they were really creative about how they did it. They looked to social networks, friends for rides, family members for financial help. And their own childhood experiences really influenced as well. So that some of them had little to no access to healthcare as a child, and others had had access, but were very aware that that was a privilege. And they wanted their children not to have that on their minds at all. And so this mother from Guatemala told me, no, truthfully, no, my children always come first, and the time or the money are beside the point. But they also talked about how that had consequences for them as moms. And that, you know, they were sort of last in line after everyone. Several of them talked about having depression. Multiple moms talked about ongoing sadness, and very few were getting any kind of treatment or support for their own mental health. And, you know, talked about how in order to pay for their kids' care, they were going without clothing that they needed for themselves, other self-care, and also without healthcare. You know, just that burden of having to be everything. So this mother from South Africa said, especially parents, you have to be everything to your children from the moment they wake up until they go to sleep. You're the friend, you're the teacher, you're the doctor, you're the nurse, you're a zookeeper, you're this, you're that, you're this. And then in a normal day, that's absolutely perfectly okay. But who takes care of the mom? And, you know, even with all that, the moms were super creative. So the next theme we came to was eternal strategies are developed to mitigate economic strain. Like I said, they had all these creative workarounds to manage limited resources. A really common strategy was to pay a little towards all their bills to show good faith. And a lot of thinking about weighing expenses that could be put off without repercussions. And another big one was resource sharing. So they talked a lot about sharing the food that they cooked, or bringing boxes of groceries from the local foods distribution to neighbors who were too afraid to go out. And one story that really stood out to me was a mother from Cape Verde who was living with multiple family members in one house. It was one family on the second floor, children and sister, and then her other sister, brother-in-law, and children lived on the first floor. And pre-pandemic, it had been a household with 5 incomes. And in the pandemic, 4 of them lost their jobs. And so they were down to just the one part-time income of the mother that I spoke to. And so it was pretty extreme need. And she kind of called a family meeting and was like, you know, we're gonna make a plan here. And they made a plan about how they were going to pool their resources, pool their public benefits. And she talked about that. She said, we don't have to waste. We try to help each other. We always do that. We always help each other anyway. Whatever needs, we just help each other. And then with the COVID and all that stuff, we did a meeting and everything. We started saving and not let food go in the trash. They also looked to external government support and to alleviate economic strain. They talked about a variety of programs that they accessed, SNAP, WIC, PEBT, energy assistance, but you know, not all received everything. It was different for everyone, but you know, and many had applied, but were still waiting to hear or were on waiting lists of one kind or another. But they talked about the positives of public assistance with really how it helped them afford other needs. So for example, if they were getting SNAP, that it helped the family redirect their budget resources to housing or healthcare or phone or the internet. But even with the recognition of how the assistance helped, there was still a lot of discussion about stigma and shame regarding needing help in the first place. And this mother from Antigua talked about it. She said, she was talking about WIC. And she said, that's the only one I've participated in. And how do I feel about public assistance? If I need it, I guess once I started having children, my pride went out the window. So really, again, the commitment to kids, but you know, some real concern about the shame and the stigma that is associated with public assistance for some folks. And so I think this last theme about racism and xenophobia harming maternal well-being and shaping access to healthcare and social services really came out of a lot of discussion, particularly around fear of family separation, and that it was really pervasive even for those who had legal status in the US. The interviews, the earliest interviews were taking place at a time when there was still some pretty intense action at the US-Mexico border, and a lot of that was really fresh with all those images and accounts of children being ripped out of parents' arms. And there was just really palpable fear and concern there. Others talked about how they'd witnessed or knew of deportations, more the point, in their circle of friends, and how that impeded access to healthcare. That some of them were feeling. It was interesting. A lot of them talked about that they were going out anyway, but they were afraid to go out, and they were sort of limiting where they were going, not just because of the pandemic, but also related to this sort of pervasive sense of fear. And one mother from St. Lucia told me, who had since become a US citizen, but she described a situation with her older son when he was diagnosed with a high lead level, and her name was not on the lease, and the doctors wanted to know where she was living. And so she said, they say he had high lead levels, so they wanted to find out where I was living and how he got it. And then my aunt was saying, oh yeah, they can take your kids from you. So that scared me to think that they would have taken my son from me. So I did not go back. So I think that, a sense of fear really was impeding their access to healthcare and also to social services. Another mother from Haiti talked about how she had first really hesitated to apply for SNAP because she was very worried. She didn't say public charge, but she was very worried about how it would affect her citizenship, and like what the repercussions would be from seeking assistance. And then even once she did get over that hump and decide that she was going to apply for SNAP, and then subsequently got her card, she didn't use it for months because she was afraid of the stigma of going to the store and actually use it, and what people would think of her, and not just what they would think of her generally, but what they would think of her as an immigrant who was using SNAP benefits. So the experiences of racism and xenophobia had really big mental health burden for the moms. They talked also about how skin color and accent were part of that, and feeling like that made them a target, being talked about experiences being publicly berated for speaking another language, being told to go back to your country. Real concern for their children's safety in relation to that. This mother from South Africa said, and when you have children, Black men, essentially, they're going to be Black men, so it affects you even more, especially if they're going to be gunned down for no reason. And so I'm not saying that they're going to, I'm worrying about it. So you constantly have to have your children guarded, and you have to monitor their every move, et cetera, et cetera. So it's mental gymnastics, of course. And I think that really speaks to that sort of all the mental moving parts that moms are dealing with. At the same time that she talked about, and she was not alone in this, other mothers talked about it too, trying to raise their children also with a sense of pride in their culture and background, and really wanting their kids to stay connected. She said, we're not trying to raise kids that have to recover from their childhood. So it was something that really came through strongly, that real strength and determination to keep children connected to their culture through language and food and holidays and connections to other people with similar backgrounds. So wrapping up sort of across these two studies, I think the thing that really stood out to me for both of these is the maternal burden and the need for a real household approach to healthcare, that it's really, we have a lot of work out there in the world that looks at children's access to healthcare, and while that's important, it's really not the full story, and that it's really important to be caring for mothers if we're trying to care for children as well. And also I would say that the maternal burden in many ways is aligned very much with experiences of US born mothers, the economic pressures, prioritizing other people in the family, working to get by, and but I think the immigrant mothers have this added pressure of worrying about family separation, worrying about their immigrant status. And then, layering onto that, particularly for mothers of color, the pre-existing racism they encounter here in the US. And though their stories were really about interpersonal experiences, but the way we immigrants as a society has a lot to do with race, and is really at the bottom of so many of our laws and policies. And then we have this extra added layer of anti-Black immigrant racism, which is its own whole thing. And so something I've been thinking about is sort of the structural vulnerability. It's a concept you may have heard of, other people have used it, really particularly related to immigrants of color, and so the really racialized, patterned way we approach immigrants of color through law and policy, even if that's not directly called out. And one example of this to me is what happened with the CARES Act last year, of the way that mixed status families were just entirely excluded from the pandemic stimulus checks. And despite the fact that there were later restitutions for many immigrants, and not all, but for many, you know, a lot of people still ended up not getting any of those stimulus checks, even though they were retroactively eligible, which meant that, you know, millions of citizen children didn't get support, and their families, and many families with mixed status didn't get support either. So I think our federal and state policy is definitely in need of a much more nuanced, equitable, and immigrant inclusive approach, and really thinking about the integration between the realms of healthcare, immigration, and social policy, which are often dealt with very separately, and the sort of alignment and need for more work and more collaboration. I know it's already happening, but more between the immigration justice and the racial justice movements. And then also thought a lot about thinking about healthcare, the need for team expansion, bringing in people with expertise in immigration and income supports, expansion of health insurance more broadly, regardless of nativity, really more true inclusion, but recognizing that health insurance isn't enough. There's a lot more. I mean, these are just some examples. The public charge piece, of course, and frankly, I think elimination of that, also the elimination of the 5-year bar. And then I think the last item here is really beyond like an equity review that is desperately needed across both federal and state levels, is community outreach. There's so much trust that's being burned, not just over the Trump years, but prior to that as well, and a real need to restore trust in immigrant communities. And yeah, I think the race ethnicity piece about identifying that, I'd love to hear from other people, but the other piece is thinking about how, you know, it's really important in research to have really diverse samples, and really deliberately thinking about examining more than one social identity and how they affect health equity, and then making sure that families are included as experts. And I just need to say that the Annie Casey Foundation funded part of my qualitative research. Lots of thanks. This work was part of my dissertation, and I have a wonderful team, including Dr. Liz Sherman here, across all of our sites, a really fantastic, diverse team. So yeah, I'll stop it there.
Thank you for that wonderful and powerful talk. We already, I see, have some questions popping up in different places. So let me start by seeing if I can use this allow to talk button. Anna?
It seems I can talk now. Okay.
Okay, great.
Thank you. Thank you for allowing me to talk, because I first want to acknowledge how important are these findings, and thanking Dr. Ettinger for this presentation. I have a question that it's more related to your findings, but also a kind of overall an endpoint question. So I first, from your findings and the analysis you showed, I wonder if you also have made this breakdown by areas within US or even cities. I know the Children's Health Watch has different cities involved in this sample. And whether these disparities that you're showing are different by cities. And the second one, I think it's very interesting that you took as reference, if I didn't understand, but that you took as reference US Black mothers, right? Which is, you know, very, very known as one of the most disadvantaged group in relation to maternal and child health. But you have shown that there are some disparities that some immigrants group are worse than the worst groups here in US. So I wonder if this is the message or your final findings, how you think this could be delivered for policy changes.
Yeah, those are great questions. So on the first one around cities, that's a really interesting question. The only one that I've really looked at is Arkansas, and that's because great majority of our white US born mothers come from Arkansas. And so, you know, some of my original, when I first, you know, saw these results, I was like, oh, this is so interesting. It's not really what I expected to see, and thought, well, maybe this is like an Arkansas effect. So I, you know, reran it looking just at Arkansas, and then also looking with, you know, taking Arkansas out, but it holds either way. But I haven't looked at it in the other cities, and they do have very different immigrant populations. So that's a really interesting thought to try that, to look individually, because, you know, every state has its own environment. So that also could be really interesting thing to do. So that's a good idea. I will try that. On the, yeah, so it's Black non-Latina mothers that were the reference, but for the US born analyses, it was US Black non-Latina mothers. For the immigrant analyses, it was immigrant Black non-Latina mothers. And I actually, to be totally truthful, ran it first with white non-Latina mothers as the referent group. And it wasn't sitting well with me, truthfully. It just felt like, you know, I'm not sure that's the best comparison. Also, although there were, you know, statistically enough to compare to, it was such a small group compared to the Black non-Latina mothers. And I talked with another researcher who does a lot of equity focused work, and I had run it already with, like, as a sensitivity analysis comparing to Black non-Latina mothers. And I took it to her and I said, well, what do you think of this? I don't really know what to do. And I don't really know how to interpret this. It's so different from what other people have shown. And she said, no, I think it's really important. You should put that as your main analysis. Like that's your largest group. Yeah, dig into it, talk about it. So I do think it's really interesting. And I think that's some of where I want to do a little more digging on the health insurance side, because then when I dug further into looking at the caregiver insurance, you know, the patterns, again, across nativity and race ethnicity were really different. So I think I have some more work to do to understand that. And also the other part of that is that it's a smaller group that we have information about health insurance for the caregivers. So it's like a subset of that larger data set. But I do think it has perhaps some important implications, and that's what I talked through with her as well, is that you know, this might mean that even though it doesn't mean that there's no risk of healthcare hardship for Black US born moms, there may be something different there, that, you know, it's having a more protective effect. There's more supportive effect than other groups, perhaps because of the sort of societal soup we're in. But also our white mothers in this sample are not sort of, the whole sample is a very low income sample. So those white mothers are definitely struggling as well. And I think it's interesting that they have higher rates of private insurance, which, you know, come with potentially higher copays, and that may be some of what's happening, is like that financial strain. But yeah, it's hopefully that answered your question. I was sort of long-winded, sorry.
Yes, I think it addressed some of the, of course, you know, the limitations of the sample. Sometimes, you know, you cannot give a complete overview of all the problem, but I think this is very interesting what you have done. So congratulations.
Thank you.
Thank you. We also have a comment and question in the chat. Thank you for sharing your work with us. Do you have, no pressure, but do you have papers published in progress or under review for this incredible work? I would love to cite you.
Oh, I wish. I do have them written. They haven't submitted them anywhere yet. They need to go through our group's review, and I'm sure they'll get torn apart a bit. Yeah, so no, not submitted yet. No, I really wish they were. I do have my dissertation that is citable, but it's the details are embargoed because I'm hoping to get these published in peer-reviewed manuscripts. But yeah, I do have an abstract though. I guess I could share that. That's citable. That's about this healthcare hardship work. So I could share that for sure.
Thank you. That would be great. And we'll look out for the papers in the future as well. We have a little bit more time for questions if there are any additional questions. Looks like Anna has a question. I think you can unmute yourself, right? Yes.
Thank you. Thanks for this presentation, Stephanie. It's really interesting. There's so much packed in this data that I don't even know where to start. But one quick question, and forgive me, I might have gotten distracted maybe for a moment, but how do you define healthcare hardships? Like what's in that dependent variable? And I was trying to think, if there's something in the way that construct is operationalized that might explain this to some extent paradoxical results regarding the role of nativity and race ethnicity. And second question, and then you can answer them at your own time, is whether in the qualitative part of your study, if you've noticed any patterns, for different kind of immigrant groups. For example, I noticed many of the quotes that you presented are, from African immigrants or Caribbean immigrants. I was thinking that the profile of many of these immigrant populations is quite different, how they arrive in the country, their immigration status, by virtue of how, the nature of how they can access the country is something's very different. Levels of education are also dramatically different among some groups. So just wondering if you dig a little bit deeper into, some of these nuances.
Yeah, those are great questions. So the healthcare hardship, yeah, it's made up of two different pieces. One is foregone care, so that the families are reporting that they didn't get healthcare they needed because they weren't able to afford it. And in the survey, we measure that as at the household level, so people other than the young child. I can't actually identify it, whether it's the mother as well. So that is something else that I haven't done yet, but I want to do, is look at the mother's report of healthcare hardship, and then foregone care for the child. And then separately is another concept called health cost sacrifices, sort of like the mirror image of that, which is that the family paid for medical care of whatever variety, and then that outlay has made it now difficult to afford other things they need, like food, housing, utilities, telephone, whatever else. And we actually do have the detail on that, of what specifically they've had difficulty paying for. Overwhelmingly, it's like the big three: food, housing, utilities. But there are also some other things that people report in there. Debt is another one that people report. The other kinds of debt, like the payment for medical care, now makes it difficult to keep up with debt. And yeah, so I didn't show this, but we actually have very low rates, which I actually was surprised by, very low rates of foregone care among the children, and really sky high rates of foregone care among other household members, which fits then with the qualitative study. It really helped explain it once I got into the qualitative data and started hearing from moms about the way they were thinking about healthcare in their family. It really illuminated that difference for me. And then the health cost sacrifices was also very high, and that was very tightly tied into child food insecurity. So if people were reporting health cost sacrifices, they had much higher rates of child food insecurity, which is the most severe level among households with children of food insecurity, which means they're having to limit children's meals and things like that. So a lot of economic distress there. And then on the qualitative study, yes, I did think, yes. I kind of I didn't call it out, but some of the things that I talked about in there definitely were different depending on region. For example, a lot of the Central American mothers particularly talked about how, you know, they lived very far from healthcare as children, and didn't have access to healthcare as children. You know, one woman talked about how she has, you know, an eye disorder that was never treated because it was too far to go to the city, or, you know, other people that maybe lived near healthcare, but their family didn't have money for it because it all had to be paid out of pocket, and so they weren't able to access healthcare. So it really sort of shaped their commitment to getting their children healthcare. And then another place that came up was certainly related to experiences of xenophobia and racism. You know, a lot of the moms who speak Spanish had experiences of people yelling at them on the street or in their places of work because they were speaking Spanish. And I think what was interesting to me was I thought I would see, oh, this fear about accessing benefits is going to be, you know, mainly people who have some sort of more temporary status or no legal status, but including the naturalized US citizens, they also talked about that they were afraid there was a stigma issue for sure. But then also reporting that they were afraid, even though they were already US citizens. So I think that's, to me, speaks to just how harmful that policy is across the board. Yeah.
Thank you. We have another question. Can you talk a little bit more about how some of these disparities, particularly those related to public program use, change over time based on some of the policies and contextual factors you discussed, like public charge, and how to tease out the effects of those types of policies?
Yeah, I mean, so obviously the qualitative research was just the one interview, but people did talk about, so I didn't ask like before and after public charge. Oh, I think one other thing that's really interesting, I will say it's like a side point, but related, is no one knew the term public charge. No one knew it in Spanish either, but people very clearly understood the concept of it because they would talk about, if I get this benefit, then the government is going to say that I can't become a US citizen, I can't change my status. So that was really interesting to me, that even though they had no idea what I was talking about, when I said, have you ever heard of this? And they were like, no idea what you're talking about. But when I asked contextually about, you know, how do you feel about it and all that, then they were very much pinpointed exactly what I was asking about, which I thought that was really interesting. On that question, there was definitely, for the mothers who were now US citizens, I asked how that had changed their feeling about being in the US and their feeling about accessing help and stuff like that. And several of the mothers talked about how it was freeing, and that they felt that they were more able to go out on the street, although, you know, then obviously we were in a pandemic. So they were talking about pre-pandemic, and that it meant that they could demand more from their employers. But still, like I said, not every single one of them. Some of them are like, now I can get benefits and I don't have to worry about it. But there were definitely, I can't tell you off the top of my head how many, but there was definitely a group that were like, yeah, I'm a US citizen, but I still am worried about what this will mean. So yeah, I think there's so much I think that's the other thing I really take away from this is, even though we know, you know, public charge was defined this way up to this year, and then it was defined this way, and now it's back, and it's this other thing. It's just confusing for folks who are on the ground. And a lot of people were there were two mothers I can think of in particular that had gotten really bad advice. And it was really hard to keep my mouth shut when they were telling me about it, because they've been talking to immigration lawyers who are giving them completely wrong information. And you know, telling me all about this. And yeah, so I think even though we may know that a policy has changed, that doesn't necessarily filter to you know, the average family. And it's still super confusing about you can be eligible, and also that it's so different between programs. You can be eligible for this, but not that. And for this group, you know, this like Venn diagram of this small subset can be eligible. And then the stimulus checks and all of the changes with the COVID relief programs just like did not help that picture at all. People were so confused about what they could and could not be accessing.
Thank you. I'm going to use my moderator's prerogative for one more quick question. I'm still kind of stuck on this idea about, I think we often think, or I often think of like private insurance as being kind of the best case scenario. But from what you're saying, it sounds like in this sample, in a way, that's not always the case, and that, you know, mothers with families with private insurance were more likely to be reporting healthcare hardships. So I'm just curious if you could talk to us a little bit more about that, like what, you know, how much do you know what insurance these families have?
We do, so the variable I have is already grouped, but we do have more detail about what people say. But yeah, so in general, Medicaid-based insurance limits the copays that people have to pay. They either have like a $0 copay or a, you know, maybe a $3 copay or something like that. Whereas private insurance, copays can be very high. They can be $30 or whatever, you know, 25, which adds up really fast. And sometimes more. And the you know, underinsurance is a huge problem with private insurance, where you know, people theoretically have coverage, but they have high deductibles or something like that. So, you know, it just in practice makes healthcare inaccessible except for something catastrophic. And frankly, that's what Arkansas has done. They've used, instead of doing the expansion, like, which is why I dug into that, because instead of doing the expansion like other states with Medicaid for the ACA, they took their expansion dollars and used it to pay for private insurance for people. But, you know, that private insurance is not great and still has high copays. So I think it's a real financial burden.
Thank you. And I just want to take a minute to thank Dr. Ettinger for joining us and kicking off our colloquium year. This was a really, really great and instructive talk. Anna had put the link in the chat before, but let me paste it again. All the information about our upcoming colloquia and our upcoming events are on the website. Our next colloquium will be on Friday, December 3rd at the same time, and we'll be joined by Dr. Rima Afifi from the Iowa College of Public Health.
Oh, cool. I'm from Iowa. I'm from Iowa City, where that
Oh,
is.
nice. Well, I hope you can join.
I'll have to join.
So thank you again, and thank you all for joining. It was wonderful to see you, you know, with quote, air quotes, virtually see you. And have a wonderful weekend, and we will see you next month.
Thank you, everybody.
Bye-bye.
Bye.